Hello and welcome to Nursing Emergencies and Nephrotoxicity. My name is David Woodruff. I'm the editor of Critical Care Nursing Made Incredibly Easy. I hope to make this incredibly easy for you too. So let's talk a little bit about nephrotoxicity that occurs as a result of any medication that the patient may be taking. So we have damage that's occurring to the kidneys as a result of a medication that could occur in one of three different ways. It could be from reduced blood flow to the kidney, or a direct nephron injury, or obstruction. In the same way that we talked about acute renal failure being either pre-renal, intrinsic, or post-renal, we can also have nephrotoxicity in the same manner. Let's take a look at how these different things occur. So here's that same nephron. I've kind of blown it up a little bit here so we can take a closer look at what's happening in causing the patient to develop nephrotoxicity. So the first case would be that the patient has a pre-renal cause. So the medication for some reason is decreasing the blood flow to the kidney. Now that could be a couple different ways. It could be that the medication is causing volume depletion, so there's not enough volume to get to the kidney. It could be that the patient is getting vasoconstriction as a result of a vasopressor, for example, and causing decreased blood flow to the kidney. But for one reason or another, there's not enough blood flow getting to the kidney. Therefore, there's not enough forces favoring filtration. So we have to have, you see that filtration piece down there. We have to have enough pressure in the bloodstream in order to be able to push those waste products out into the renal corpuscle. The next type is called intrinsic or intrarenal type nephrotoxicity, and in this case here we're having damage that's occurring directly to the filter itself. So here the glomerulus, this is the actual filter. Think about it like a coffee filter, and if the drug is burning holes in it, let's say for example you have a coffee filter and you're dripping acid on it and it burns holes in your coffee filter. Well, your coffee filter isn't going to work right. And the same thing happens here with intrinsic type of renal failure. This is the type of renal dysfunction that is the worst, because if we damage the filter is going to eventually recover by putting scar tissue in place instead of that nice healthy tissue. So that would be like putting tape all over your coffee filter. Coffee filter isn't going to work very well with tape all over it. You're not going to have as much filtration as you had previously. The third type then is called obstructive or post-renal. So we have obstruction of the urinary tract as a result of this medication. Several medications will crystallize in the urinary tract, and then that causes obstruction of the urinary tract. Then urine will back up into the kidney, and we won't have those forces favoring filtration. There'll be too much pressure in the renal corpuscle that's pushing against those waste products trying to get out of the blood. So then again, we still don't have adequate filtration. Pre-renal type is fairly easy to fix, so we restore the blood flow. Post-renal type, in many cases, is very easy to fix. We just remove the obstruction, and then renal function goes back to normal. So again, the one that really is going to be the biggest problem is the intrinsic type, because we're damaging the actual filter. Let's talk a little bit more about pre-renal. So again, this is not enough blood flow or pressure getting to the kidney to maintain that force favoring filtration and then having normal filtration of the kidney. As I mentioned previously, we can avoid this by maintaining adequate blood flow to the kidney. So whatever that medication is that is decreasing blood flow, we can stop the medication, we can rehydrate the patient, whatever the case may be, in order to restore blood flow. On presentation, we'd expect to see oliguria. There's not enough blood flow getting to the kidney, therefore we're not going to have the filtration we should normally have, and urine output will decrease. Remember, when we're looking at these terms as far as renal function goes, oliguria means we have less than 400 milliliters of urine output a day. Anuria means we have less than 100 milliliters of urine output a day. So it doesn't mean that the patient has no urine output. It just means it's markedly decreased to the point where we're not having the kind of filtration we should have in order to be able to maintain homeostasis. The next piece in filtration is a decrease in FeNA. That's our fraction of excreted sodium. This is a better indicator than looking at our BUN and creatinine. However, we can also look at creatinine clearance as another indicator of renal function. There will be an increase in urine osmolality. So our urine is going to become more concentrated, have more sodium in it, it's going to be more concentrated. Our urine osmolality will go up as a result, and specific gravity will go up as a result of having more concentrated urine because we don't have enough fluid coming to the kidney in order to dilute it. So our prompt action is let's discontinue the medication, stop the medication, restore our normal volume, and then hopefully the kidney will be able to recover. Intrinsic is the next type, so this is the damage directly to the nephron, and this is going to be the part, the type that's really difficult to recover from, because again, it's like burning holes in the filter, and it doesn't heal up well in order to be able to have normal renal function again. There's a couple additional things that happen during this process, burning the holes in the filter. We have this oxygen-free radical formation, and the formation of oxygen radicals causes additional injury beyond what this chemical is causing to the kidney. Oxygen-free radicals are produced in the body as an attempt to try to kill off bacteria. However, in this case, that additional oxygen-free radical production is going to actually cause more damage than it's going to help. If you notice on the right-hand side over here, you can see a partial list of medications that can cause intrinsic type nephrotoxicity. So there's a huge amount of medications that can cause this, lots and lots of medications. One of them you see on the list there, NSAIDs, can also cause a pre-renal type of renal failure. So we have to be careful with these medications and watching patients' renal function. As we talked about before, and we'll talk about again, when we see decreases in patients' urine output, we need to look beyond whether or not it's just fluid volume, because there could be some changes in renal function as well. So this is the part that's being damaged. We want to stop the medication, and we want to try to restore normal function if we can. Because there's so many different types of medications that can cause intrinsic type nephrotoxicity, we're going to focus on the internist's quartet. The internist quartet include radiocontrast dye, aminoglycosides, NSAIDs, and ACE inhibitors. Those are the big four that we're going to be concerned about as potentially causing intrinsic nephrotoxicity. This is especially important if your patient also has one of the other risk factors, for example, maybe decreased blood flow to the kidney. On presentation, the urine volume may be normal initially. This is because, remember again, the filter. Think about that coffee filter. If I'm burning holes in the coffee filter with my acid, volume is still going through, right? But as the kidney tries to heal and starts putting tape on that filter, then we're going to start to see oliguria because the filter's not going to work as well, and we're going to have less filtration occurring as it starts to heal. So oliguria will ensue, but it's not going to be the initial presentation like we see in pre-renal. We'll also see an increase in our fraction of excreted sodium, an increase in eosinophils in the urine. We want to discontinue the drug. We want to try and flush it out. So in the same way, if you've got acid that's burning a hole in your coffee filter, if you flush a lot of water through it, hopefully you'll dilute the acid enough to move it through the filter without causing a lot of damage. If your patient has thrombotic, thrombocytopenic purpura, then we may have to use plasmapheresis. The third type is called obstructive, and an obstructive type of nephrotoxicity, our medication is crystallizing in the urinary tract, causing an obstruction in the same way that a urinary stone would be causing an obstruction of the urinary tract. Some of these medications that can cause obstructive nephrotoxicity include acyclovir, sulfonamides, methotrexate, indinavir, and triamterene. The presentation will be a decrease in urine volume because we have an obstruction of the urinary tract. And because these crystals are blocking the urinary tract and causing damage to the urinary tract, just like a stone would, so it's irritating the inside of the urinary tract, we're going to see red blood cells, white blood cells, and crystals in our urinalysis. So our prompt action is going to be, let's discontinue the drug, volume replacement, so try and push lots of volume behind it to push that crystal on through the urinary tract, just in the same way we would do with a stone. And urine alkalinization, so that we're making the urine less acidic in that acidic environment, then that stone or that crystal is more likely to form. In general, proteins tend to make the urine more acidic, and fruits and vegetables, carbohydrates tend to make it more alkaline. So our takeaways are, nephrotoxicity can be pre-renal, intrinsic, or post-renal. We want to be looking for potential causes of all three. Careful administration of medications so that we're hopefully preventing or at least decreasing the renal damage that is occurring. Watch the renal function during administration. Maintain fluid volume. So this is one of the big keys. The less fluid there is rushing on through that kidney, the more chance the drug has to cause destruction. Again, thinking about that filter, and we're putting acid on the filter. The more water I'm running through that filter, the less chance the acid's going to burn holes in the filter. Thank you for joining me for Nursing Emergencies Nephrotoxicity. My name is David Woodruff, and until next time,